I'd like to welcome you to Columbia Ethics Grand Rounds. I am Sandra Soo-Jin Lee, Professor of Medical Humanities and Ethics and Chief of the Division of Ethics here at Columbia University. I am absolutely delighted to welcome you to our March Ethics Grand Rounds event entitled Improving Equity, Transparency, and Accountability in Research in the Age of Mass Incarceration. For those of you who are joining us for the first time, the Ethics Grand Round series is a quarterly series organized by the Division of Ethics in the Department of Medical Humanities and Ethics, which was founded in 2018 and is chaired by Bernard Schoenberg, Professor of Social Medicine, Rita Sharon. Ethics Grand Rounds has been developed with the help of our Ethics Grand Rounds Planning Committee that include faculty members from both uptown and downtown campuses at Columbia and NYP. The goal of the Division of Ethics is to integrate humanistic perspectives and ethical reasoning towards alleviating human suffering and promoting justice and equity in scientific practice, biomedical research, and healthcare. Our faculty and staff and students aim to cultivate multidisciplinary, community-focused research on ethics and to conduct innovative, high-impact bioethics research at the intersection of biotechnologies, health equity, and social justice. The theme of our Ethics Grand Rounds this year is incarceration, policing, and health equity. According to the Vera Institute of Justice, the incarceration rate in the U.S. has dramatically increased over the last 50 years, growing by 400%, resulting in the highest rate of incarceration in the world. Those who are incarcerated are disproportionately people of color, immigrants, and people experiencing poverty. Our criminal justice system and the brutality of policing results in significantly higher rates of chronic disease and serious mental illness. This series centers human indignity and societal toll that incarceration and policing has on community, family, and individual health as a critical yet often neglected focus of bioethics. In today's session and through this series, we hope that together we will reflect on the meaning of justice and consider how we as scholars, clinicians, scientists, educators, students, and more will respond in our own work. In so doing, we will interrogate incarceration and policing as an American public health crisis, ask how structures of racial inequality are created and reproduced, and consider the ways in which practices and policies concretize inequities that cause human suffering. We have an opportunity to ask how each of us will take up this challenge, and we hope the series will catalyze action that will directly address incarceration, policing, and its health effects both within and outside of academia. So before I turn to our speakers today, I'd quickly like to go over some logistics for the session. We ask that all attendees please abide by the Code of Conduct, which you can find at the bottom of the Ethics Grand Rounds page, posted in the chat. We have a live closed captioner present for this event. So if you do want closed captioning, please turn on the CC button at the bottom of your screen. If you do not enable the CC feature, captions will not appear on your screen. So please do turn that button on if you would like that. We will reserve the last half hour of this event for discussion. So please use the Q&A button, which you will find at the bottom of your screen, to write in questions for the panelists, and you can do that at any point during the session. You can also register your enthusiasm for a question and elevate it up the list by using the upvote button in the Q&A box. The chat remains available for further engagement, and we will be posting relevant links to resources referenced in today's discussion there as well. And then finally, if you have any logistical questions or troubleshooting needs, please email us at mhe_ethics@cumc.columbia.edu at any time. So it is now my great pleasure to introduce our speakers. Dr. Emily Wang is a professor in the Yale School of Medicine, director of the Seshi Center for Health and Justice, director of the Health Justice Lab, and co-founder of the Transitions Clinic Network. She leads these initiatives with focus on identifying and applying strategies to improve the health of individuals and communities impacted by incarceration. I also want to add that Dr. Wang is a 2022 MacArthur Fellow, a detail that she does not include in her official bio, but as the director of the MacArthur Fellows notes of this year's fellows, they are, quote, excavators uncovering what has been overlooked, undervalued, and poorly understood. They are archivists reminding us of what should survive, end quote. And this fits well as Dr. Wang has, through her clinical care and research, brought this largely invisible complex of health needs and inequities of incarcerated people into public conversation and debate. Our second panelist is Dr. Lisa Puglisi, who is an internist and addiction medicine specialist and assistant professor of medicine for the Yale School of Medicine. Her clinical care, education, and research efforts are primarily focused on improving the health and well-being of people who have been impacted by mass incarceration. She directs a transitions clinic in New Haven and a statewide network of similar programs, which are part of a national network, the Transitions Clinic Network, focusing on addressing the health needs of people returning to the community after incarceration. She is also director of education for the Sechi Center for Health and Justice. And finally, we have Michelle Daniel Jones, who is a sixth-year doctoral student in American Studies at New York University. Michelle's dissertation focuses on creative liberation strategies of incarcerated people. As an organizer, collaborator, and subject matter expert, she creates opportunities to speak truth to power and serves in the development and operation of task force and initiatives to reduce harm and end mass incarceration. She has joined the Second Chance Educational Alliance as a senior research consultant, the Survivors Justice Project, and serves on the boards of Worth Rises and the Correctional Association of New York, as well as the advisory boards of the JAMI Sisterhood, the Education Trust, A Touch of Light, Urban Institute, and Ithaca's Higher Ed in Prison Project. So as you can see, we have an amazing set of panelists here to lead our discussion. Please join me in welcoming Dr. Wang, Dr. Puglisi, and Ms. Daniel Jones. And I'm going to hand off, I think, to Emily. I think, there we go.
Perfect. I can't say enough how excited we are to be here in conversation with you, Dr. Lee, and also with my friends and colleagues, Michelle and Lisa, for what I think is going to be hopefully a great way to spend our lunch times together, really kind of digging into something that's near and dear to all of us, but in particular, hopefully will exactly hold us to new levels of accountability, thinking about how it is that we engage those that have been impacted by mass incarceration into research and make them more visible, as you state. So what I'll do is move through, and our time for the three of us is broken up hopefully into about 15-minute segments. And in this first part, I'll cover kind of the epidemiology of incarceration, touch on the history and ethical considerations of research in correctional systems. I won't do justice to this as my colleague, Ms. Jones, who is a real historian, but I will touch on it. Then Michelle's going to go into her part of exploring what doing research within a carceral system felt like as a scholar. And then lastly, I'll turn it over to my colleague, Lisa, who will discuss a new framework on conducting research to account for structural vulnerabilities within carceral systems. And so, I think it's always important to start with this, which is that mass incarceration impacts millions of individuals directly in our country. And it's not just, but we will start with those that are directly impacted. So at any given point in time, 1.9 million individuals are behind bars in our prisons and jails. That's 1.9. There's an additional almost 5 million individuals that are within the system of correctional control. And so these are people in our communities that are on parole or probation. So all told, 7 million under a system of correctional control. When you look at these statistics too, I think it's important to note that 80 million Americans have a criminal record. Half of all adults in this country have had an immediate family member incarcerated. And so what this means then is that the toll is large and it's concentrated in certain populations and among certain families. As many of y'all know, there are, as Michelle indicated, there are disproportionate impacts on poor families of color. And so, you know, when you look back at statistics right now, 1 in 3 Black men have a lifetime likelihood of imprisonment. 1 in 17 have, 1 in 6 rather, Latino men have a history of imprisonment. And compare this to white men who 1 in 17 have a lifetime likelihood of imprisonment. Similarly, while incarceration is less common for women, Black women were more likely to be incarcerated in their lifetime. And again, when you drill down into Black families, they are, of course, disproportionately more likely to be affected by incarceration. And so almost half of all Black Americans have had 3 or more immediate family members who've been incarcerated, compared to white American counterparts, that rate is about 5%. And so based on the work of sociologist Becky Pettit, the New York Times ran a headline a few years ago that said that 1.5 million Black men are missing from daily life between the ages of 25 to 54 because they're dead or they're incarcerated. This is one of the infographics that emerged from the New York Times at the time. And in yellow, you can see the places where they're disproportionately missing. And in the purple, places where they're overrepresented. And while this has long been known that Black men are more likely to be locked up, more likely to die young, the scale of this combined toll is large. More than 1 out of 6 Black men aren't around to be parents, husbands, working citizens. The higher imprisonment of Black men account for 600,000 of the men who are missing. And early death is thought to account for 900,000 of this missingness. Homicide is the leading cause of death for young African-American men, and heart disease is that for older Black men. And this missingness, and then we're going to drill into this a little bit more, has significant bearing for understanding the health of Black men, health disparities, and our achievement of health equity. So let me dig into this just a little bit more. We did a study a while ago wanting to explore how mass incarceration, kind of this grand impact that it's had on our population, has affected the study of health disparities, and especially how incarceration might impact loss to follow-up in large cohort studies. So we identified, again, all studies funded by the National Heart, Lung, Blood Institute, which followed participants for at least 2 years and really wanted to look at Black-white disparities in health. And so here on the left-hand column, you can see studies that are commonly referenced, commonly the basis of our understanding of the root causes of heart disease. So Cardia, ERIC, Jackson Heart Study, MESA. And we first wanted to ask how many of them actually followed men and women. Again, these are all studies that recruited people in the community. We wanted to see how many of them actually got IRB approval to follow people into prisons and jails. And as you might suspect, none of them did. We also then wanted to know how many actually asked about an exposure to incarceration history. Again, this is a common exposure, especially among minoritized populations, and only 1 study did. Cardia. And so what we did then was looked at the loss to follow-up rate, again, in certain demographic groups, Black men, Black women, white women, and we estimated how much of this loss to follow-up might be due to incarceration. And what we did was got data from the Bureau of Justice Statistics, looked at places that they were recruiting and actually estimated how much incarceration was happening in these populations in the places where recruitment happened. And so here are the data for Black men from this study. And what you can see is the actual loss to follow-up in the red bars And in the blue bars, the estimated loss to follow-up. And what we found was that anywhere from 15 to 65% of the loss to follow-up was likely due to incarceration. And so, this is just making the point that the scale at which we incarcerated and have incarcerated over the past 5 decades is certainly impacting our nation's knowledge of racial health disparities, since most studies don't follow participants into prisons and jails, don't include institutionalized participants, and don't ask about exposure to incarceration. And this missingness of who's represented in the data is here in health studies, but is also in our historical colleagues as our in historical archives, as our colleague Michelle Jones will touch on. This is the heart of our conversation today. For me, this is a challenge because almost all health conditions are overrepresented and worsened behind bars, especially once people are released. And I just show this briefly. So these are data, as you can see, from the single population-based study that asks about incarcerations. All these are coming from the National Survey on Drug Use and Health. And these are common chronic health conditions on the left-hand side: hypertension, diabetes, and obesity. And I've bolded here areas, again, among people in jail, people in prison, and probation. And you can see that there are higher rates of common chronic health conditions that are overrepresented in populations that have criminal justice involvement. And what strikes me, I think, and is important to kind of, I think, internalize is that while these are common chronic health conditions, there's very little known about why this is the case and how it is that we mitigate these conditions. And this has been the case and has certainly come to the fore given COVID-19. So as we all know, COVID-19 wreaked havoc in our nation's prisons and jails. 90 of the first 100 largest outbreaks took place in correctional facilities at the beginning of this pandemic. And as a result, thousands of people who were incarcerated or who work in corrections got COVID-19. And here I present some data from the COVID Prison Project with blue rates of COVID-19 in blue for incarcerated people, and red for the staff, and the general population here in green. And the point here is that compared with the general population, incarcerated people and staff had about 3 to 5 times the rate of COVID-19 infection. And a study published in JAMA, again, the death rates from COVID were 3 times higher than in the general population. And so, of course, as a primary care provider, as someone that cares for and works alongside individuals who have family members incarcerated, who they themselves have been incarcerated, a core question for us in the center was how best we could protect our patients, their families, the communities from COVID. And again, when you go to the literature, there's almost nothing about incarcerated settings and pandemics, nothing about incarcerated settings and vaccines. And from my surprise, of course, this missingness wasn't a surprise. But when we turn to the history, it indicates why this might be the case. And so to start, as I'm sure many of you are familiar with, there's a long and brutal history of conducting research in carceral systems in the United States. And so here's the book, Acres of Skin, that are detailing well-known historical examples of Dr. Klingman's studies in the Holmesburg prison. As you'll know, probably, that more than 90% of phase 1 clinical trials, so these are clinical trials of drugs testing only their safety in the United States, were conducted in carceral systems at this time. And so the vast majority of phase 1 trials were happening only behind bars. And this included testing of things like retin-A, Agent Orange, radiation, chemotherapeutic agents. And so many incarcerated individuals were enrolled without informed consent, and certainly without any federal oversight of these studies. And then, of course, in the 1970s, this changed. In 1976, the National Commission on the Protection of Human Subjects of Biomedical and Behavioral Research instituted a moratorium of sorts of research that involved testing of drugs and vaccines. And so this commission then recommended that research involving prisoners that posed more than minimal risk or was not studying the process of incarceration and didn't directly improve the health or well-being of individuals and prisoners shouldn't be conducted unless the reasons for research were compelling. Similarly, around the time the federal government began overseeing research, institute the subpart C of the Common Rule. And so the prisoner IRB stipulations were created. And what this meant is that individual researchers who wanted to conduct research among populations which have criminal justice contact, even for minimal research, had to get, of course, additional approvals. And so in 2003, and this is in concert, and just to flip back here, as you see that the rates of incarceration, especially among minoritized populations, grew. Then in 2003, the Institute of Medicine, now the National Academies of Sciences and Engineering and Medicine, was asked to revisit this issue, especially given the increase of prison populations and especially given the increase of incarcerating minoritized populations. These were populations, again, that were disproportionately with higher rates of communicable diseases at the time, especially HIV, hepatitis C, tuberculosis. And so these recommendations, and again, I'm just kind of giving an overview, were as follows: that there should be a consideration of the risk versus benefit versus categorical exclusions of research. That secondly, and importantly, incarcerated people and correctional leaders should be included in decision-making, that there should be collaborative responsibility. They noted that in the guidance in past, they had not included anyone that had been incarcerated, nor correctional leaders. And then they also recommended an expansion of the Office of Human Research Protections Oversight. And so they noted that while the office was created, there wasn't a place where they're systematically categorizing what research was taking place. However, few of these recommendations have taken hold, and so there's still little research to be conducted. And as a result, we know less and less about the people who have, especially those people from marginalized populations that have contact in the criminal justice system. And so early on in the pandemic, there were, real discussions about what COVID and what the experience of having been incarcerated was like for individuals with COVID. Here is a brutal photo of a person that requires oxygen, and you can see the kind of real tension in this photo is that the tank of oxygen is held outside solitary confinement, and so the individual's health is placed secondary to concerns of safety and also truly it's a photo of punishment, of the structural violence that happens within prisons. And so this is the setting under which, of course, COVID is taking place, recognizing that there is structural violence in the very delivery of healthcare behind bars. And yet many individuals were getting COVID and concerned. We at our center are surrounded by individuals who've been incarcerated, and it is they, especially those that had spent long sentences behind bars, whose loved ones were still behind bars, that were saying that they wanted more access to anything that was available to individuals in our community. So whether it be vaccines that were under trial, Paxlovid that was under trial. And so we initially penned a thought piece in JAMA positing that whether or not COVID-19 clinical trials should be taking place in correctional systems. And I won't spend too much time discussing this, but essentially the kind of crux of it was that incarcerated people ought to be included in decision-making bodies, that racial equity should be a guiding lens in clinical trials and correctional systems. We should ensure the receipt of efficacious vaccines in healthcare if clinical trials were to take place, that this is critical, recognizing the structural violence of healthcare behind bars. We ought to convene a federal oversight board. And then lastly, to study the implementation of vaccines in correctional systems. In opposition, of course, there was good, healthy discussion about whether or not this would make sense. And, Professor Karamet Ryder published in Dissent, does a public health crisis justify more research with incarcerated people? And I think it's important here, the conversation that she raises, and I think is an important one, but if carceral institutions itself imposes extreme social deprivations, as that photo indicated, research participation among those incarcerated might never be ethical. So I end with this, just before I transition, it's from incarcerated people that who know intimately the structural violence that exists behind bars that disagree. And I share this letter that came from an incarcerated student who, after listening to one of our SAGE Center webinars, he writes describing an idea he had for a study. And he starts saying that he initially wasn't necessarily that amenable to studies inside, but after listening and thinking and living through this, he writes, another suggestion I would have that would follow a questionnaire survey that he started thinking about, of course, is to set up a pilot program of inmate volunteers, those were his words, who would either participate in ongoing clinical trials for COVID or any virus for that matter. And it goes on, of course. And so I think that this sets up our conversation this afternoon well. This letter to me speaks first and foremost to the knowledge and untapped human potential of the millions of people who are locked behind bars. And it raises important questions about who's included from research, who reaps the benefit from research, and why they haven't ever been included in decisions about scientific governance. And it's my belief that a more inclusive science at least invites that conversation now. And so with that, I'm going to turn it over to my friend, scholar Michelle Jones.
Good afternoon, everyone. Thank you for having me. So what I'm going to talk about is our particular project that we did at the Indiana Women's Prison, wherein we did primary research about the facility in which we were incarcerated in from the early 1970s. And so if you'll go to the first slide, the first 1870s. And so the Indiana Women's Prison, where we were incarcerated, is historically known as the first public prison for women in the United States. It was built in 1873. It was built because women were living in a co-ed facility at the Jefferson Correctional Facility for men. And women were sexually violated in that situation, and children were born, and guards were given the right of open use of the women in the facility. And so some benevolent reformers decided that they would work to separate the women from the men. And the prison opened in 1873 with 18 women from the men's prison. Next slide. So our project started in 2013, and our idea is that we were going to write the first 15 years history of the Indiana Women's Prison. It was a collaborative effort. Each person in our class had their own field of inquiry, and we did meta discussions in order to find synthesis across the carceral spectrum. We received archives from primary source archives resources coming into the facility from the Indiana Archives and the State Library. And my main focus was data analysis. I think it's important to know that we had the support of faculty members from DePaul University and Indiana University, Purdue University, Indianapolis, to assist us in setting up the research project. And if you'll go to the next slide, you'll see a photo of all of the participants of women who participated in the project. Of those women there, 8 of the women have 8 bachelor's degrees, 2 have associate's degrees, and 3 are currently enrolled in some college programming. 2 of us are in PhD programs. So let's move further into the story. So we thought we were going to tell the feel-good story of the year by researching Rhoda Coffin and Sarah Smith as women benevolent prison reformers, right? They banded together to create a safe and rehabilitative environment for quote unquote fallen women. Sarah Smith had a history of wartime service, including working with freedmen and soldiers, distributing clothing. Rhoda Coffin had a history of missionary work and visiting prisons across the country. According to Coffin, she handpicked Sarah Smith to run this prison because she felt like this woman was most equipped to do it, right? If in our next slide, you'll see that they created the facility with the idea that they were going to reform the fallen. The reformatory was created to house women convicted of all crimes, including prostitution. But as we began our research, we learned very early on that none of the women convicted of prostitution were at the facility. We wondered where they were. We did some additional, we sent our archivists and our librarians back to the facility to learn, back to the libraries to find more information about where these women were, right? Where these women were. And we had them search county jails. We only found a few. But the fact that the reformatory held no women convicted of prostitution would later prove super invaluable for our research, because we had learned that prostitution led to the growth in a short 5-year period of multiple institutions, carceral institutions, to house women. The Richmond Home for Friendless Women, the Indianapolis Home for Friendless Women, the Magdalene Laundries, the House of Good Shepherd, and ultimately the Indiana Reformatory Institution for Women and Girls, right? So after 5 years after its opening, we learned, though, that So the fact that the reformatory held no women convicted of prostitution was super important to our research. And if you'll go to the next slide, the women were actually held in Magdalene Laundries, right? But the women who were held in the reformatory experienced incarceration just as bad as if they were incarcerated in the co-ed facility at Jeffersonville. A fallen woman was anathemic to decency on all accounts. These women were considered unruly in conduct, and particularly if they were found masturbating, they were punished severely. The women in these institutions were physically, mentally, and emotionally abused by these benevolent reformers, including ducking and being slapped with slippers and locked in closets, bread and water diet, and violence overall was seen as a primary tool for reform. And one of the most famous doctors that worked with Marlon Sims and Dr. Marlon Sims and other famous early doctors who created the field of gynecology and obstetrics, Theophilus Parvin, he subjected the women in the prison facilities to clitorectomies and ovarectomies. And so what's important here is that we need to understand that these women and men in that time period saw the crime and the status of those women as fallen women as a way in which to tag them forever in a status as fallen, that there would be no redemption for them. And in fact, when the women began to speak out about the treatment, there was several investigations in 1881 and 1887. And all of the board members of the facility, as well as some of the media, closed rank around the benevolent formers, and nothing ultimately happened to these prison benevolent formers and their supporters for creating a sexual engendered violence situation inside the prisons. Now, this is important because it paralleled a lot of the experiences that incarcerated women, we ourselves in the classroom, discussed that we had gone through. Now, maybe we weren't experiencing the ducking and the beating of slippers, but we do know the story of Prinsola and other women who were left in solitary confinement so long that they ultimately committed suicide and hurt, and they were also sexually violated by guards in solitary confinement, right? So the point about this is that the primary failure of these prison benevolent reformers is the assumption that these reformers' ideals of what a woman or a young girl is should be the only standard in which to measure womanhood and adulthood. and that these ideas would ultimately be secured by violence. And that is as true as in 1873 as it is today. In our next slide, you'll see a picture of the reformatory. And I only show this picture so that you can see that they divided the facility on one side with women coming from the county jails, and the other side was where they incarcerated girls 18 years and under. So in our project, we had very unusual methods and difficulties in executing academic research, but it should be weighed against the riches of discovery, the expansion of ideas and viewpoints, and the development of a clearer view of history. So we weren't able to compile our own archive. We depended on another reader's understanding of our question. We depended on another person's thoroughness. We depended on another person's time availability, and we had no internet access. However, through all of that, we were able to develop some key findings that I think are important for us to consider when we talk about incarcerated women doing research about the facility in which they were, the history of the facility in which they were incarcerated in. And so what the IWP History Project teaches us, and if you'll go to the next slide, is that gender responsive carceral systems criminalize sexuality of women and girls and facilitate their silencing and their disappearance, particularly when it was coupled with religion. The initial premise of these institutions is false, that women have to be incarcerated in order to be reformed or helped, especially if they're labeled fallen or deviant. The initial premise of these facilities were gendered and sexist. Women had to be removed from their homes and society to prevent them from tainting good soldiers, good men, and because they were seen as a burden. What else we found in this project is that the operations were often corrupt. These heterotopic spaces of secrecy are without real oversight and transparency to balance the unequal power dynamics between all of the prison officials and the women and girls incarcerated within. And so what happens in those situations is that those spaces proliferate gendered and sexual violence. And the idea of an effective carceral system under this banner of what current mass incarceration is, and from its history, is just completely imaginary. An effective carceral system is imaginary. It is rooted and constituent and formed in violence, and it operates out of violence. So we have to be careful when we consider the latest gender responsive program. We have to be careful when criminologists, sociologists, and the like focus on reform and tweaking existing systems, when they are not also addressing and pushing for implementing solutions that address the structural formations in our society that feed women into the carceral state. So if it doesn't counter the original purpose, premise, and operation of the facilities, it's just simply reinforcing the carceral state. So we have to be critical when historians and scholars tout scholarship as definitive. We know that women and people of color are not even addressed as a population in many of the texts from the Enlightenment period. We as scholars have to ask pointed questions about race, sex, gender, and even criminality of scholarship. And so it's on us to critique, analyze, and ultimately write or rewrite the dominant narratives that have prevailed in leaving out women and girls, people of color, the poor, and the incarcerated. So we have to be prepared to tackle and write narratives to go alongside the dominant narratives that leave us out, right? And so this is what the History Project teaches us as well. And if you'll go to the next slide, incarcerated scholars interested in doing this work, we're uniquely equipped to do it because we understand the lived experience of incarceration from an embodied lived experience. And so our lived experience of the carceral state provides an insider valuable lens of critique that is invaluable to understanding how to analyze data that comes from a research question. And as a result of that, we knew the right questions to ask. We knew to ask, where were the women who were convicted of prostitution after the historians told us that they were everywhere. It took us time to excavate the fact that they were funneled into carceral institutions across the state of Indiana. Incarcerated scholars in our project, we asked questions of the data that historians at that point had not asked. And so, in fact, so that we could do what? We could find those people who are missing in the archives. It's a major important work of our project to tell the untold stories so that we have a more complex and more detailed and more nuanced understanding of the carceral state from its origin stories. So this history project is about that first prison in the country focused on women only in the United States, and how they have throughout history taken those processes that have continued on today into our current experiences of incarceration. So it's important to think about who is not heard in the telling of that story and that history from the first prison, public prison for women in the United States. And our project sought to do that. As a result of that, we've created a new methodology. And we call it if you go to the next slide, the embodied observer. And so the embodied observer focuses on the subjectivity of incarcerated women as epistemically privileged. We are privileging our right to be knowers of our own experience enough as a way to analyze, as a way to, as a lens in which to understand and archive. And so the other process in that methodology is qualitative inquiry. And so we use that as a way to excavate the subjugated knowledges, right? Qualitative inquiry, as opposed to statistical measurement, focuses on the lived experiences and the complexity of people's lives. It cares about the ephemeral processes of human endeavors. Qualitative methods recognize subjugated knowledge, which may be delicate, fragmented, and require reconstruction from various sources. For example, in order to tell the stories of some of the women that we recorded in our upcoming book, we had to take pieces from newspaper, we had to take pieces from legislative testimonies, we had to take pieces from other texts that talked about women in general, in order for us to piece together, use informed speculation, informed, taking our context of the time in order to piece together the story of these women. Michel Foucault suggested that subjugated knowledge is hidden within the dominant historical narratives and has to be desubjugated, excavated, and justified because they are disqualified by the powerful. Right? And those are the people who write the dominant narratives, write the histories. And our process and our methodology, we're also countering a double disqualification, right? In our particular case, as incarcerated scholars in the project, we grappled with that double disqualification. The disqualification that comes from our own incarcerated status, and a disqualification that comes from the disqualification of the opinions of our historical subjects and the incarcerated women that we brought to life from the book. There's also an advantage in researching the past, because it allowed us to safely research the past as a strategy to critique the present in a carceral system, which did not allow us to research our current experience. We are forbidden to take surveys, to collect data on ourselves as a population incarcerated. So we had to safely research the past in order to effectively have a critique of our current. Because at no point would the facility or staff at the Department of Correction permit us to research our current living conditions. We sought to also funnel our research into art, because we understand that populations that we are seeking to educate about this history need multiple ways of engagement in order to interest them in something that most people would say is the history and it's long gone. But as I keep saying, it impacts our present. So we wrote a play that goes along with this research project in order to educate people who need data to come to them outside of academia, the journal article, the official book, etc. Our work is not participant observation or PAR or CPAR. Our methodology is not quite participant observation as seen in standard ethnography because it's embodied by our position as enforced captivity. And it's not quite a participatory action research project because it's focused on the origin stories and reaching through time to better understand the causes and effects in our present moment. Lastly, the applicability of our new methodology is valuable in other carceral spaces because the concept of an embodied observer captures the difference between the body under literal confinement and the same body subject to the taint of criminality, a type of confinement post-incarceration. So the embodied observer, however, is not limited to the experience of incarceration or of the physical periods. The carceral geographic spaces writ large are key for the inscription of containment that remains on the body. And therefore, this methodology could apply to other carceral spaces like asylums, orphanages, hospitals, mental institutions, et cetera, et cetera. So lastly, what I'd like to show is that we have been able to write and present our findings in many venues. Beginning to speak specifically about the History Project, but from that, again, to be able to critique our current space of mass incarceration, we were also able to continue to present, and most of that was done while incarcerated. Our next slide is that we have several published articles that have come out with our findings about this work over time, and really excited about the ability to get our work out in official venues. Next, we have some awards that have come out of our History Project. There's a couple there that not listed, but the point is that our research has gained recognition, and our methodology as well as a valid way in which to use the embodied experience of incarceration as a lens in which to review the archive. And next, we are publishing our book with the new press. It comes out in next month in April. We're publishing our findings to produce a body of knowledge that is designed to be read alongside dominant, sanitized narratives of prison benevolent reformers. And we're supported in this effort by Dr. Kelsey Kaufman, and Dr. Elizabeth Nelson, who are both historians who fully support privileging our experiences in the study of topics that are connected to our lived experience of incarceration. As a result of our work, we've been able to launch and work with other projects across the country. And the next slide will show you a couple of places where other deep dives into origin stories that can about the past of women's incarceration and men's incarceration, and how that is bleeding into our reality of mass incarceration today, are ongoing in other places across the country. And so lastly, the point here is that we seek to counter epistemic violence. Epistemic violence is where we are denied a right to be knowers, denied a right to be participants, often subject to erasure and therefore missing from the archive. And so we therefore epistemically privilege our right to be knowers of our experience and worthy as researchers researching mass incarceration. Lastly, women represent the fastest growing population in prison, yet because our numbers don't match that of men, women are suffering without adequate access of healthcare, limited programming, educational opportunities, and subject to epistemic, gendered, and sexual violence, and the racialized criminalization of who we are. We have shown with this project that this has been the state of things from the very beginning. This is why it's important to have us be a part of excavating these subjugated knowledges, right? So any movement that doesn't include justice involved women and men is just short-sighted and ignorant of history and its lasting effects upon us all. Particularly when you think about and sit with what is a crime and who gets criminalized? What is criminal to leave incarcerated people out of the development and understanding of research projects that literally impact their lives? Thank you.
Thank you, Michelle and Emily. So next, I would like to build off of some of these concepts that Michelle and Emily introduced and walk you through a new framework for conducting research in prisons with incarcerated people that we've devised, really specifically to open research, include incarcerated people, and counter this missingness that you heard them both describe. We came to this work through some early webinars that we held at the Sage Center, where we focused on COVID topics that were the most relevant to people who are detained and who work in carceral systems. Arguably, the most exciting thing that came from them, from these webinars, were the questions that we got from incarcerated students. So we sent readings into prisons ahead of time and asked people to send us their questions. We posed these questions to our panel members. You can see Michelle on there with us back on that webinar. And then we sent the answers back into incarcerated students through transcriptions. And it's exactly this topic that has been near and dear to me as a primary care physician and researcher, which is really centering the voices of people who have been most impacted by mass incarceration in all of the work we do, whether it's clinical, programmatic, or research-based. So through this, through a National Institutes of Drug Abuse grant that we already had, we had subsequently this opportunity to apply for specific funding through this RADXUP mechanism to really investigate further exactly this topic. And so we put forth this grant that we were awarded, where we really in AIM 1 focused on the ethical concerns and potential solutions to addressing COVID-19 vaccine and testing with a real focus on opening up research. This is the team that we put together, a really broad array of expertise represented here, with over a third being directly impacted by mass incarceration, and others bringing expertise around having cared for people who are currently informally incarcerated, conducting research on incarceration and health, as well as historical, legal, and ethical expertise. We dug into the historical archives. Thanks to Michelle and Elizabeth Hinton. We looked to analogous situations in other disciplines. We conducted interviews with incarcerated people and really wrote, thought, and debated amongst ourselves with a focus on grappling with ways to create a framework that would expand access to research for incarcerated people while simultaneously attending to these ethical considerations for how to best do so. And these are the considerations most germane as laid out by the National Commission for the Protection of Human Subjects in Biomedical Research back in 1976, like Emily mentioned, where we really dug into the second principle, whether quote unquote prisoners are so situated as to be able to exercise free power of choice, i.e., can there be true voluntariness in prisons during informed consent to uphold the principle of respect for persons while also attending to justice. And we started by saying that true voluntary consent for research, as is expected in the community, is an illusion in the carceral context, especially in the absence of formal considerations of coercive structures and conditions of deprivation. While many scholars have argued that these conditions of confinement should categorically exclude incarcerated people from the bulk of research, we started from a point of view of saying that true voluntary consent across many contexts is very nuanced. This is not a new observation. Legal scholarship, for example, has featured decades of discussion around the voluntary nature of consent for stuff like warrantless police searches of vehicles. Searches conducted after obtaining quote unquote consent account for 90% of warrantless searches conducted by the police, and the vast majority turn up with nothing, no illegal activity. Thus, Tracy Mears, who was on our team, has argued that an individual may be deemed for purpose of constitutional law to have voluntarily consented to the search of their belongings, because the court assesses voluntariness through a balance of an individual's privacy interests against the state's interests. But in this context, is really, she argues, difficult to denominate this balance as a true consent to a search. And in response, in certain locales, police agencies now require officers to provide individuals a notice of acknowledgement, which essentially is a notice of their right to refuse the search. And they sign this saying that they have been so informed. And in this way, there's this acknowledgement of the inherent situational coercion undermining the true voluntariness of the subject's agreement. Such regulations are sort of the first step to recognizing, I think, this tension between a person's ability to consent and structural coercion. So our framework, which builds off of a framework set forth by Paul Farmer to conceptualize structural violence and how it operationalizes, this one maintains that the personhood of incarcerated people is foremost in research policy and decision-making, that consent is possible, even in settings of coercive structures, that clinical research is advanced only in contexts in which the potential benefit to the incarcerated person is clear. Not that there is a clear benefit, but that the potential for benefit is clear, and that developing detailed policies and practices along with external oversight is necessary to advance justice. Our framework uses a socio-ecological approach to understand these different levels of coercion as set forth here that operate in carceral facilities. So this is not exhaustive, like truth be told, but it's really meant to generate discussion and provide a launch pad. It also may set forth scenarios in which research should never be permitted. So while it allows for like what could allow research to be permitted, it may determine in some places that research can never be permitted. It seeks to identify ways to attend to each level of coercion and research, and is meant to force researchers to have to attend to these levels in their plan, and not just focus here at the interpersonal research or participant dyad level, where historically most discussions about coercion have been nested. So let's go through some example of how a research plan might address structural coercion. Starting with the structural level, the outermost ring. When considering a clinical trial in such settings, the trial in question cannot be, because of the health systems inside and deprivation, cannot be the only access to certain elements of necessary clinical care. For example, if a new drug is being tested for, let's say, effectiveness in preventing severe COVID-19 infection, it cannot, let's say it involves frequent testing for COVID-19, this trial cannot be the only access to testing in the facility. That would be, we would put forth too coercive. But there are several ways that the trial could proceed. For instance, researchers could need to provide testing supplies, could even have to provide some of the periodic testing itself, at least for those who need it, as a matter of proper medical attention. Alternatively, the IRB might review the healthcare delivery in that setting and review the researcher's plan and decide that because of the lack of testing and the inability of the researcher to provide it, that the conduction of research in that setting would be just unethical and could not proceed. Likewise, as noted here, the trial could not be the only access to information. If the trial involved some sort of informational campaign or provided, pamphlets of information to people who were enrolled in the trial, it couldn't be the sole way to figure out and get access to information about a new dangerous condition or a cancer or what have you. Those are just some examples. Drilling down to the next level of social community, moving in one circle. In the carceral setting, this would refer to connections with correctional officers, peers, and family. And to attend, and in this circumstance, addressing this at the correctional officer level might entail having correctional officers complete standardized training on structural coercion in facilities, the same way many of us in any work environment have to complete standardized trainings. Likewise, if this was the only way, if somebody was consenting to a trial, but really wanted to be able to speak to family, they would have to have some way of accessing family potentially in order to get a second opinion, in order to get a second set of ears to understand, like, is this worth it? I'm not sure, instead of kind of pushing people towards it without access to other bases of knowledge and support. At the next circle inwards, at the interpersonal level, these are factors traditionally at the researcher participant dyad that impact voluntary participation. And they could even include a researcher's understanding of structural coercion. I don't think this is common knowledge, and that might involve doing a training. Likewise, it might involve a participant needing to sign an acknowledgement form, just like in that police example I gave, where they are the understood levels of structural coercion in that setting are described. How they are being addressed or not able to be addressed is detailed, and the person signs acknowledging that these have been addressed, or at least presented to them, and that they are aware. At the smallest level and at the individual level, this is the level of coercion that is talked about much in the ethical literature, often in the community level, whether it's people with severe mental illness, people who use drugs, people experiencing poverty, and ways that studies can be coercive to them at the individual level. We put forth another level in this unique environment, which is length of incarceration. So we suggests that length of incarceration might need to be considered when consenting to a trial or understanding the appropriateness of a trial for that individual, given that, due to sentencing laws, like some people, while most people end up coming home, some people are going to be in there for life. We've gotten letters from people who say, this is where I'm spending the rest of my days, and I would like to be able to have access to research. Alternatively, somebody who's coming, getting released in the next 3 months may be better served accessing that same type of research in the community where those levels of structural coercion were more mitigated. To improve equity overall, formerly incarcerated people and incarcerated individuals must be involved, as Michelle beautifully highlighted, in the governance, conduction, and regulation of trials. We can no longer come up with these regulations without their deep and authentic input, and they must be also involved in overarching federal and state policy, governance, and with on IRBs, part of IRB rule creation and regulations. I think even at a deeper level than the standard prisoner representative. And lastly, let's talk about what this framework does not address in entirety is transparency and accountability. Though they're not totally addressed, we believe that there are actions that can be taken. There must be federal and state oversight of all studies taking place in carceral settings. And this should be a dedicated office, clear responsibilities for oversight, and with the ability to halt research, even if it's not federally funded, if it is found to be unethical. These clinical trials would also need to be listed publicly to allow for community monitoring and to maintain transparency. And there are other examples just like this, such as clinicaltrials.gov, where OHRP could immediately start listing all of the trials that they have to approve to be performed in prisons and jails. Relatedly, there must be clear protocols and structures for reporting study protocol violations and concerns about coercion. Such protocols would be anonymous, free, simple to conduct and submit, and without long delays between reporting and action. How this happens, how this operationalizes, is not entirely clear yet. I hope that we're presenting you with ideas that spark questions, that spark you presenting some of your ideas back. I mean, this isn't solidified yet at this level, but I think that what's needed is very clear. While we hope that this talk today sparks conversation, and most importantly, that you take away that to truly uphold principles of justice, we must conceptualize research involving incarcerated people using a contextual rather than a categorical approach that recognizes heterogeneity amongst people, amongst carceral facilities, and that, as Michelle said, really eliminates the singular view and centers the personhood of incarcerated people, allowing for the creation of processes that will make possible access to pressing research that attends to the inherently structurally coercive environment in which people are detained in this country. I'll stop there and pause to turn it over for questions, and back to you, Sandra.
Great, wonderful. Thank you so much for these powerful presentations. You have offered a wealth of resources and references, some of which we've added to the chat. And I just want our audience to know that these links to the resources and the recording of this event will be available on the division website after the event. As I'm looking at the audience list, I can see that there is tremendous wisdom and experience in this Zoom room. So I encourage you, audience members, to submit your questions and comments in the Q&A box. But just to get us started, and maybe what we could do is, could we take down the slides so we could see folks? Great. I want to come back to just the different ways in which you think current policies should change. And all of the panelists have highlighted that historically, of course, incarcerated people have been considered a vulnerable population. With this comes concerns around coercion. Some people have argued that because of incarceration, these individuals will never be able to offer voluntary consent to participate in research. And, Emily, you described the historical abuses that have been borne out in this country that has really fueled this position. I'm going to ask you to tell us more about how you see this balance between what Michelle beautifully described as epistemic violence and this issue around coercion. And I wanted to ask you if you could speak to this the concepts of minimal risk and the compelling need for research in the context of structural violence incarceration. And so just to give you a little bit of runway here to tell us a bit more of how you're thinking about this calculus. And
I'll give you the microphone first if you want it.
Yeah, no, so I appreciate that, Sandra. I think that at the heart of this is that incarcerated people are denied personhood, right? They are automatically set to be ineligible personhood by a civil death that happens through the conviction of a crime. And people begin to think of that person of incarcerated as like not being a person, like not having capacity, not having a brain, not having any ability to do or think for themselves, right? But they are actually people. We are actually people who can actually read, right, and look at a project and decide if we like to have participation. My concern is that some of the things that we've talked about in our other programs is that there needs to be oversight into the ways in which the DLC administers or participates in any type of research project, because DLC has a tendency sometimes to not respond to the needs of the incarcerated population. And so if there's a research project and there needs to be feedback, there also needs to be like a check and balance from an outside party, and that could be the researching party, that has the interests of the incarcerated population at heart, because we are in a vulnerable state with a population with prison officials who have power over them, if you will. And so, but that doesn't negate the fact that we have capacity to as the person who wrote that wonderful letter said, enter into a research project that we understand that might be valuable to us.
Yeah, and I thank you, Michelle. I would add to it too, what a number of people we work with have told us is like their life is not minimal risk. Their average daily life is not minimal risk. And so the realities in which they find themselves are entirely largely violent and dangerous, even at the health level, right? Like COVID, living with being detained in a correctional facility during COVID-19 was just a dangerous reality of itself, many magnitudes higher than living in the community. And so I think the issue of minimal risk becomes really nuanced in that setting. I know you want to say something, Emily.
Oh, I wanted to kind of take it on also is just that one of the ways that I've been thinking about this too is that there is risk in not knowing. Like there is risk in the absence of knowledge. And there's, as a primary care provider, I've experienced it for 15 years, taking care of people that have come home from prisons and jails, where they're asking me, why do I have a greater risk of X disease? What's happened? What's driving that risk? How do we mitigate? How do we change the healthcare system so that there isn't risk? And the kind of deep part of it is that I have to turn to my patient right there and say, we just don't know. There is no study, right? And that is devaluing of a person's personhood. So, I think to kind of frame it also is that there is a deep risk of not knowing, and also that risk kind of undermines the personhood of millions of individuals, because it is kind of a categorical definition of risk.
Mm-hmm.
That they didn't participate in that decision making. That's the place that it when patients get it, it's like, well, who came up with these? I guess real simple questions, questions that I think are of value. Who came up with these guidelines? Where, like anyone that's ever been incarcerated involved, and especially, when the guidance was designed, people were talking about the end of prisons in the early 1970s. That ain't the case now. And so we just have a real different scenario, which begs for a reexamination of our federal policies.
Yeah, that's great. And I don't know if you see Margaret's question in the chat, Margaret Cedar. She says, in terms of consent process that acknowledges structural coercion, are there concerns about the cooptation of and by pharmaceutical companies to exploit people behind bars to more quickly bring drugs to market? So I just want to, I know you guys certainly have a response to that, but I just want to say that private healthcare providers have also been coerced and incentivized to use certain drugs and inside the carceral space, but there is no checks on there's no checks on the contractual relationship between the DLC and the privatized medical entities that serve incarcerated populations. And so what can help is the outside researcher who is not built into a contractual relationship with the DLC to take a look at some of these things in an actual research process, right? But because that situation that you're talking about there happens every day under the auspices of contractual relationships between private healthcare providers and the Department of Correction.
I completely second that. I mean, I think that's kind of the desert of knowledge that we have now, that we live in, which is like, I wish that we could go on and search, some, federally publicly available data set to see kind of what private companies are inside, where trials are going on inside, what's been approved, what's not been approved, to understand the landscape. And the reality is, in the absence of knowledge, we just assume, and it's not a wrong assumption, we just don't know. And so this is getting kind of to the issue of needing needing transparency, and then subsequently needing kind of a governance body that holds us all accountable to the guidance that's put forth.
Right. And there's a few external oversight mechanisms around the country that are great models of that, right? The Canny in New York, and the one in Philadelphia, and of course, John Howard in Illinois.
So in the chat also, Margaret Cedar has asked this question about therapeutic misconception. And I wanted to ask you all how you see that potential risk where incarcerated people might think that they are signing up for something that is basically healthcare. Perhaps this relates to Karamet Ryder's question as well, where she's asking about how do you manage, how do you balance the people's agency while acknowledging that they are potentially desperate for healthcare. How do we think about this potential risk?
It's interesting. I think it's an important question, and the answer is nuanced. I would say this is not the only scenario in which this struggle exists, right? Like, what is a phase 1 trial to somebody with advanced cancer? While there's no guaranteed therapeutic benefit, right? And you sign the paperwork saying that you understand that. Almost all patients and family members I've had who have signed up for phase 1 trials, like, it gives them hope. That is why they sign up, even understanding that. So I think there are other, as a full disclosure, not an ethicist, I am not best to pull those examples from the ethical literature, but I think there are a multitude of examples of people who find themselves in that very same position, and practices that can be learned off of that.
Okay, great. Good. So Holly Taylor has a few questions, and the first one is, isn't the first step isn't a first step in revising, I think, to the revision to the current federal regulations is to allow broader access to those who are incarcerated. Current regulations limit the type of research that can be conducted already. Does anybody have a response to that?
I think that is one of the steps that we would propose. I mean, I think really kind of, if I peel back, the first step is to have incarcerated people weigh in on the guidance. I mean, I think that to me is like proceeding forward without kind of a real interrogation of how our policies have been created, who has been at the table and who hasn't been at the table in these, intervening 50 years. I think, we'd be remiss in that. I also think that certainly kind of in times of emergency and during a pandemic, I would have loved to have seen more robust discussion around that in those moments. And of course, like, pandemic preparedness needs to happen always. And so we have the opportunity right now to jump in on this and kind of hopefully convene, a different sort of panel that is impaneled differently and is more inclusive in its nature. Hi, Dr. Taylor.
Great. Good. Let's see. So can I ask you a question from Ineke Cordova? This person writes, I'm a genetic counselor assistant, and after a brief search, I have been made aware that there's not a single publication on genetic counseling in prison, and only 1 or 2 blog posts about the concept. How difficult do you think it would be for an incarcerated person to receive diagnostic genetic testing?
What a fantastic question. And we're semi-obsessed with this here in New Haven right now. So it's very timely because we've been seeing a number of people coming home who have like really strong family lineages of things. And I have one patient in the 10 years I've been doing this who recently came home telling me he had Lynch syndrome because his brother, he lost multiple family members to early cancers in the community while he was incarcerated. And some researchers at UConn got special permission to like go in and test him. for the genetic mutation, which gave him information that totally changed what we did. I was like, let's get on this. You know, you need a lot of stuff done to make sure that you don't have cancer too. And so I think you're absolutely right. I'm not surprised about your findings and the real lack of evidence on that. I think that it's really important though. And there's very little access, just anecdotally speaking. But I wonder if you all have other thoughts too.
I would also just say that's a perfect example, which represents the kind of gross underrepresentation of minoritized populations in genetic studies, in epigenetic studies, understanding kind of what are root drivers of disease. And again, these are studies that then, identify new treatments for certain diseases. And so without kind of representation of all of our populations and the diversity of genetic ancestries, then we don't kind of come to different sorts of mechanisms, different sorts of genetic basis for disease, because we haven't included these folks in studies. So, I mean, I think that ties it well. It's like there's a literally concrete application to what you're saying, which is that they're not getting genetic testing. That's one, that's a problem, right? And then secondly, they also, often are not participating, certainly behind bars, they're never participating in studies of genetic ancestry and kind of ties to disease. So I appreciate that a lot.
Great. So Joanna Crane has a question. She thanks the panelists, and she writes, often it is correctional authorities who ultimately decide whether or not research can be done. Often they don't allow even minimal risk projects. Do the panelists have any strategies for addressing this behavior barrier?
So we have seen film companies come in, TV companies come in, and 90 Days in Jail or stories about prison life come in, and they pay this Department of Correction facility $5,000 a day or the like to come in and film. And there's very little consideration about the trauma that those people might go through by reliving their criminal history or telling their story on camera. And so one of the ways I think is all about the packaging. If it's coming from the space of medical assistance, medical help, medical research, as opposed to academic medical research and I think it'll have a better chance of coming in. And I think also if there's an incentive, a financial incentive to conduct the research, I know it sounds horrible, but sometimes that's a consideration. I was surprised at the access that Lifetime got in our facility, but until I realized that they were paying $5,000 a day just to walk around with a camera. And so I think there's financial incentives, and then I think there's how it's packaged. If it comes in the auspices of like, this is a medical research project for medical health and things like that, I think it has a greater receptivity from an academic project. And I know that it just sounds, and I think that may offer opportunities to have relationships with the private entities that come in and provide medical care, the private corporations. Maybe there's a way in which to partner with them because they already have the access. They already are coming in. They already are providing the services. But the DOC is motivated by those kinds of things, right?
I think, Michelle is bringing up some important points, which is like, the benefit both to kind of incarcerated people, the benefit to the institutions, the medical practice, et cetera. And even sometimes, the benefit to those that work there. Like there has to be kind of hopefully measured benefit that's directly applicable to the healthcare or to the kind of work environment or living environment there. It has been helpful for us in our work, again, in making long relationships that enable us to do this sort of research and work and clinical care. But the second is that there really still is, and I think it's important to note, and this is going back to the framework that Lisa presents, a range. There's, if you've seen one correctional facility, you've seen one correctional facility. There's a range of how kind of systems are governed, operated, coordinated, a range of kind of the structurally coercive practices that exist, the range of kind of facility awareness, previous experience with research. And so we'll all know them. There's some that are just really good at it, have done it for 30 plus years. And that partnership is good. And they're kind of keen to the certain nuances of doing research. And then ones that really are just, they shouldn't be doing research at all. They might be doing it, but they shouldn't be doing it all. And so I think that this is the important point of just kind of cluing in that, yes, sometimes that there are barriers and sometimes there's a good barriers, like they shouldn't be doing it and they should not be doing it and don't do it, right? And then others, it's more that they actually might be really great partners, important to partner, and need more help and kind of understanding what good governance of research protocols would look like, what sort of training the correctional officers would need, what sorts of additional resources and supports to make it so that research is done well, done ethically, and done so that it really is of benefit to the individuals that live and work there. And that's worth investing in, as opposed like the TV crews.
Right. Because a lot of it, most of that's exploitative, right?
Yeah.
And so again, I like the idea of what is a benefit to the entire population, right? I think about some projects that I've recently seen where they went in to do a survey of the population about COVID and about the conditions of confinement, but not just focusing on the incarcerated population. They also surveyed all the staff in custody to get their view of what it was like working in that environment. And so it felt more inclusive approach to finding out what's the meat of what's going on to the incarcerated population by casting a wider net to be more inclusive of everybody who is experiencing that carceral environment.
Absolutely agree.
So I have to say, I feel like we're just getting started in terms of thinking through some models of engagement and what inclusion means in this context. And there's much to talk about, but unfortunately, we're at the end of our time. I just want to take a moment to thank our speakers today for catalyzing a really important set of questions. And I'm hopeful that we can continue talking about these questions as a group. Thank you so much for participating today, both to our audience and to our panelists. I'd also like to thank the Ethics Ground Rounds organizing committee for their support in planning this year's series. Thank you to the Division of Ethics staff, Tiana Sipapur, Dunya Alami Nasif, David Lamb, Shauna Benston, and Rachel Yarmolinsky for their critical support of this event. The recording of this event will be soon posted on the Columbia Division of Ethics website. We will have our next Ethics Grand Rounds on May 2nd, so stay tuned for that. We also invite you to register for our next LC Friday Forum, which will be on March 10th next week, entitled "The Genie is Out of the Bottle for Polygenic Screenings of Embryos, Where to From Here." And our next Bioethics in Film from Screen to Seminar event will be on April 12th. We will be screening Aftershock and have a panel discussion about that film. Lastly, we invite you to take a look at other events being hosted as part of Academic Integrity Week. To receive information about these and other events, we invite you to subscribe to our Division of Ethics newsletter. The link, as well as all the links mentioned above, will be posted in the chat. And then finally, I ask you to please fill out the post-event survey. We take your responses very seriously, and they really help us inform our future events and how we do things. And so we really value your feedback. We really appreciated that so many of you joined us today. I wish you a wonderful week. Thank you.
Thank you all.
Thank you for having us.
Oh, thank you.